Good afternoon, everyone. Welcome to the Clinical Sciences Keynote session. I'm very excited to have Dr. Lynne Mofenson with us today. Lynne, I consider a role model and a mentor, and I'm really happy that she agreed to come and speak to us today. So Dr. Lynne Mofenson is a pediatric infectious disease specialist who directed domestic and international research and clinical trials on prevention and treatment of pediatric and maternal HIV infection at the Eunice Kennedy Shriver National Institute of Child Health and Human Development for 26 years. She currently serves as a senior HIV technical advisor for the Elizabeth Glaser Pediatric AIDS Foundation Research Program, evaluating implementations of interventions she studied at the NIH, and serves as consultant to the World Health Organization, UNAIDS, UNICEF on HIV, and more recently on COVID-19 in children and pregnant women. So areas that are very close to my heart and to many in the audience, I'm sure. So today she will speak to us on something that has, powered over our life the last 2 years: SARS-CoV-2, COVID-19 in pregnancy, and potential for mother-to-child transmission. Over to you. Thank you, Lynne. Looking forward to your talk.
The slides are up, yes?
The slides are up, yes.
Okay, good. Good afternoon, everybody. This slide has my disclosures. So let's start talking about prevalence, impact of infection in early pregnancy, epidemiology, and symptoms of SARS-CoV-2 in pregnancy. So are pregnant women more likely to acquire SARS-CoV-2? Most overall population studies don't provide pregnancy status. On the right, you see a national population seroprevalence study from Scotland that used residual specimens from antenatal clinics in blue and primary care clinics in green. And you can see that the antenatal and primary care seroprevalence during the same time period are relatively similar. The bottom figure shows you cross-sectional seroprevalence study in Sweden of symptom-free blood donors in blue and pregnant women in purple that were sampled 2020 to 21. And you can see that there's a steep rise in seroprevalence after the start of the pandemic in both groups, and that blood donors and pregnant women showed similar seroprevalence rates and increase over time. So the prevalence of SARS-CoV-2 infection in pregnant women differs by sampling strategy, and these are going to be data from a systematic review of 73 studies, including over 67,000 pregnant hospitalized women. And overall, the prevalence of SARS-CoV-2 positive RT-PCR was 10%. So with universal screening, where RT-PCR was done on all pregnant women presenting at labor and delivery, overall SARS-CoV-2 prevalence was 7%, as you can see in the box. However, with symptom-based screening, when RT-PCR was done only if there are symptoms of infections or a history of close contact, as you can see in the figure above, SARS-CoV-2 prevalence was 28%, not surprising. So what about the prevalence of SARS-CoV-2 antibody by gestational age? So this study evaluated SARS-CoV-2 antibody in 372 pregnant women attending first trimester screening at 10-16 weeks gestation, and 502 seen in the third trimester at delivery at 3 hospitals in Barcelona. Overall, 14% were seropositive, and if you look at the table in the red box, you can see that antibody positivity was similar in the first and the third trimester, 15 and 14%. But while there was similar SARS-CoV-2 seroprevalence, symptomatic infection and hospitalization were significantly more frequent in women with positive SARS-CoV-2 serology in the third trimester compared to the first trimester. And if you look at the pie charts, you can see 70% asymptomatic in the first trimester, only 52% asymptomatic in the third trimester. So what is the impact of SARS-CoV-2 infection in early pregnancy? There are a number of case reports of miscarriage with early pregnancy infection, but of course there's a bias towards reporting of adverse outcomes. A study from Italy compared SARS-CoV-2 infection using RT-PCR or antibody in 100 women with first trimester pregnancy losses cases and 125 women seen for first trimester ultrasound with an ongoing pregnancy control. And you can see in the table that SARS-CoV-2 positivity was 11% in women with abortion, spontaneous abortion, and 10% in women with ongoing pregnancy, not significantly different. Another study in Denmark looked at a little over 1,000 women in the first trimester with and without SARS-CoV-2 antibody positivity. They saw no increased risk of pregnancy loss with infection and none of a separate group of 36 women with pregnancy loss in the first trimester had SARS-CoV-2 antibodies. So what about the risk of pregnancy loss with infection before 20 weeks? And these are data from an ongoing US national prospective cohort study of pregnant women who underwent testing and are being followed longitudinally. And they looked at 109 women enrolled at less than 14 weeks gestation as outpatients, all asymptomatic. 94 tested positive for SARS-CoV-2, 15 were negative. And in the table, you can see gestational age at enrollment is similar. And the rate of early pregnancy loss was 6% in the positive women and 6.7% in the negative women. So the rates of early pregnancy loss was not significantly different. And it also compared favorably with the 10% rate of miscarriage among clinically recognized first trimester pregnancies in the US before the pandemic. So as seen in the overall population with SARS-CoV-2, there's a disproportionate rate of SARS-CoV-2 infection among pregnant women of color. And on the top, you see data from a universal SARS-CoV-2 testing of pregnant women delivering in Chicago. Overall seropositivity rate was 7.7%. And in the table, you can see compared to women with a negative result, RT-PCR positive women were more likely to be Black, 28%, or Latina, 54%. The middle table is SARS-CoV-2 seroprevalence in over 1,200 pregnant women delivering in Philadelphia, 6% seroprevalence, again, higher rates in Hispanic and Black women compared to white women. And then moving to the United Kingdom, a national cohort of 427 women in the table, you can see 56% of pregnant women admitted to the hospital with SARS-CoV-2 were from Black or ethnic minority groups. And there appears to be a disproportionate rate of severity of SARS-CoV-2 among pregnant women of color. And these are data from the CDC evaluating the severity of COVID-19 disease among over 23,000 pregnant symptomatic women in the US with positive PCR, and there were 34 deaths. And in the table, you see Hispanic women made up 29.7% of pregnant women, but 41.2% of deaths. Black women made up 14.5% of pregnant women, but 26.5% of deaths. And in contrast, white women made up 23.5% of pregnant women, but only 8.8% of deaths. So like HIV, we now have a new pathogen with the same disparities, and these are likely sociodemographically related. And this slide shows you a cross-sectional evaluation of 434 pregnant women in New York City delivering at 2 hospitals that were doing universal SARS-CoV-2 PCR testing. 71 women, 18% tested positive, and they were able then to link positivity rates with socioeconomic status and demographic data. And they found the probability of infection was associated with lower median neighborhood household income, higher neighborhood unemployment rate, higher number of residents per unit, and neighborhoods with more than one resident per room. Now, the majority of infected pregnant women, like non-pregnant women, are asymptomatic. This is that meta-analysis of 38 studies reporting on the symptom status in sites where universal testing was done of women presenting in labor. 906 women were positive on RT-PCR testing, and you can see from the pie chart that 73% of these women were asymptomatic. So do symptoms differ in pregnant versus non-pregnant women with COVID-19? And this is the meta-analysis now on 82 studies reporting clinical manifestations of infection in pregnant women, and compared with non-pregnant women of reproductive age who had COVID-19, pregnant women were less likely to have symptoms in the red box, to have fever, the green box, dyspnea in the blue box, or myalgia in the purple box. So let's now look at the impact of pregnancy on SARS-CoV-2 disease. So are pregnant women with COVID-19 disease more likely to be admitted to the hospital? And early data from systematic reviews in the CDC suggested that pregnant women had similar COVID-19 disease course as non-pregnant adults. But we have to ask, are all non-pregnant adults the correct comparison group? And this table looks at hospitalization, ICU admission, and case fatality percentages by age group. And there is a significant relation of age with disease severity. The outcomes of COVID-19 patients show you, if you compare the red box to the blue box, you can see there are significantly lower rates of hospitalization, ICU admission, and mortality in the 20 to 44-year-old childbearing age group than in the overall age group. So comparison with the overall numbers is not appropriate. And more recent studies have demonstrated increased rates of hospitalizations, ICU admission, mechanical ventilation, and in some but not all studies, death in pregnant women compared to age-appropriate matched non-pregnant controls. So this is data from the Living Systematic Review being done at the UK, identified 92 papers, almost 50,000 pregnant women, and over 586,000 non-pregnant women of reproductive age hospitalized with COVID-19 that reported on maternal outcome, all-cause mortality, ICU admission, invasive ventilation, and ECMO. And you can see that ICU admission, invasive ventilation, and ECMO were significantly more common in pregnant women with COVID-19 than non-pregnant women with COVID-19. And older age, higher body mass index, pre-existing comorbidities, and preeclampsia were all risk factors for severity of COVID-19 in pregnancy. These are data from the US, and they compared severity of COVID-19 disease among over 23,000 pregnant and over 386,000 non-pregnant women of reproductive age with positive PCR. And you can see for all of the parameters, ICU admission, mechanical ventilation, ECMO, and death, there is a significant increase in pregnant women with COVID-19 compared to non-pregnant women with COVID-19. So what about the effects of SARS-CoV-2 variants on incidence and disease severity in pregnancy? And this is a recent prospective study of pregnant patients diagnosed with SARS-CoV-2 in Texas. And they assigned a variant era based on greater than 50% of local surveillance having either Delta or Omicron predominance. So in the blue, you see pre-Delta, the green, you see Delta, and in the pink is Omicron. And in the chart, blue is non-severe cases and the orange is severe or critical cases. So compared with the pre-Delta period, both Delta and Omicron were associated with an increased incidence of infection, 3.1-fold for Delta, 10-fold for Omicron. And compared to pre-Delta, Delta was associated with the almost 3-fold increase in severe or critical illness, but Omicron with an 80% decrease in severe or critical illness in pregnancy after adjusting for vaccination. So let's look at the impact of SARS-CoV-2 now on pregnancy and pregnancy outcome. These are data that were presented at the recent virtual CROI from Africa. And this is 22 sites in 6 countries. They looked at women of childbearing age admitted to the hospital and tested for SARS-CoV-2 and looked at the dual interaction of pregnancy on SARS-CoV-2 and SARS-CoV-2 on pregnancy outcomes. So first, looking at the adjusted relative risk of outcomes in SARS-CoV-2 infected women by whether they were pregnant or not, with pregnant women who are SARS-CoV-2 infected in red and non-pregnant women who are SARS-CoV-2 infected in green, and looked at a variety of outcomes. And you can see an increased risk of ICU admission, oxygen therapy, and mortality in pregnant compared to non-pregnant SARS-CoV-2 infected women. And the graph shows you the cumulative incidence of mortality. Now, this then looks at the adjusted relative risks of outcome in pregnant women by whether they are infected with SARS-CoV-2 or not. In red again are pregnant women with SARS-CoV-2, and in green are pregnant women who are not infected with SARS-CoV-2. And you can see an increased risk of ICU admission, oxygen therapy, and mortality in pregnant women with SARS-CoV-2 compared to pregnant women without SARS-CoV-2. So is pregnancy modified by COVID-19 disease? And in this study from the US, they compared women with and without COVID-19 giving births from an all-payer database that included 20% of all US hospitalizations. Women with COVID-19 were younger and more likely Black or Hispanic and to have different comorbidities. And they did an adjusted analysis with a propensity score adjusting for this. And in the adjusted analysis, COVID-19 mothers had a higher adjusted odds of C-section in red box there, preterm in the orange box, hypertensive cardiac or thrombotic disorders in the blue box, ICU care, mechanical ventilation in the green box, and death in purple, than pregnant women without COVID-19. So what is the effect of disease severity on adverse outcomes? And this is from a US study called the GRAVIT study at 17 hospitals. And they compared maternal and neonatal outcome by maternal SARS-CoV-2 status and disease severity. So you see on the left, maternal outcomes, on the right, neonatal outcomes, and they compared not COVID positive, asymptomatic or mild COVID, and moderate, severe, or critical COVID. And in the red boxes, you can see that for most of these outcomes, it is significantly increased in women with moderate, severe, or critical disease compared to those who are asymptomatic and mild disease or those who don't have SARS-CoV-2. What's the risk of stillbirth in women with SARS-CoV-2? And this comes from the US, evaluating a database of 1.2 million deliveries in a hospital-based administrative database. And they compared the rate of stillbirth between women with and without proven SARS-CoV-2. Overall risk was 0.65%. And there was a significant, almost twofold increase overall in stillbirth with SARS-CoV-2. And this was seen both for early and late stillbirths. And when they compared the pre-Delta in blue to the Delta period in pink, there was a greater increase, fourfold increase with SARS-CoV-2 during the Delta variant predominance. What about the impact of COVID-19 by HIV status? Very little published, but these are data that were presented at CROI from Botswana using the Tasambo birth surveillance infrastructure, where they began doing routine COVID-19 screening at delivery, and they looked at outcomes by HIV and COVID-19 status. So there were over 20,000 deliveries, about 56% of them were screened, 11,500 about, with 539, 4.7% COVID positive, higher rates during Delta. And in the red box, you see HIV positive women, the vast majority of whom were on treatment and on treatment at conception, were more likely to be COVID positive than women without HIV, 5.6 versus 4.3. So this chart looks at adverse birth outcomes by COVID-19 status. And you see a number of adverse outcomes on the left, comparing COVID positive to COVID negative women and an age-adjusted risk ratio. And you can see high rates of adverse and severe adverse birth outcomes in the COVID positive women, and particularly note the stillbirth. This then looks at maternal mortality, and maternal mortality was high with COVID, particularly during the Delta period, but as you can see, it didn't differ by HIV status. Now, this is a little complicated. Let me work you through this. This is the number of different outcomes. And in blue, you see HIV positive women who are COVID negative. In orange, you see HIV negative women who are COVID positive. And then the yellow shows you HIV positive women who are COVID positive. And just looking at the graph, you can see that the highest rates of adverse pregnancy outcome were in HIV positive women with COVID. And that's compared to HIV negative with COVID and also HIV positive without COVID. So there may be an interaction here. So I want to talk a little bit about drugs for treatment. And the usual situation for use of drugs in pregnancy is existing with one picture. We have no idea what we're doing. New drugs are approved and marketed years before studies in pregnant women are conducted, if any are conducted at all. And none of the clinical trials of COVID-19 drugs or vaccines included pregnant women. So this is a table of the available treatments of COVID-19. And it gives you the approval, how you administer it, when it should start. And the things I want you to pay attention to are human pregnancy data, preclinical reprotox data, and then FDA pregnancy language. And a number of references are at the bottom. So for remdesivir, which is FDA approved, given intravenously, there were no clinical trials, but there is clinical experience and observational data showing safety in pregnancy. And a pharmacokinetic study presented at CROI shows no differences with pregnancy. And the preclinical reprotox data look good. The FDA language is insufficient data. Monoclonal antibodies, a number of different monoclonal antibodies are listed, single IV infusion. And monoclonal antibodies are generally safe in pregnancy, have been given for a number of other diseases. The FDA language is insufficient data. Paxlovid, which is a combination drug that includes ritonavir, has no real human pregnancy data, except that we know that ritonavir from experience with HIV appears safe. There are no animal data that are concerning, and the FDA language is informed discussion. And then finally, molnupiravir. And here we have a black box warning because there's not data in pregnancy, but animal data suggest potential teratogenicity. So it's not recommended for use in pregnancy. So I want to move in turn and talk about mother-to-child transmission of SARS-CoV-2. And is it feasible? And what data do we have to date? So what are the requirements for in utero transmission? So in order for in utero transmission of a pathogen from a mother to child, the pathogen must be present in maternal blood to let the pathogen reach the placenta. It has to be able to cross the placenta to reach the fetus through either infection of placental cells or disruption of the placental barrier, and it needs to be able to cause infection in the fetus. So how often is SARS-CoV-2 found in the blood? Well, viremia does occur, but it appears to be infrequent. And the figure shows you a meta-analysis from 28 studies with data on SARS-CoV-2 RNA in over 1,500 blood specimens. So it was found in 0 to 76% of blood specimens, but the two that had the largest amount found had very, very small numbers. And the pooled estimate is 10%. Now, SARS-CoV-2 viremia is more likely in patients who are critically ill and correlates with very high IL-6 levels. And these are data from 48 patients with SARS-CoV-2. Viremia was found in 10%, and it was exclusively found in critically ill patients, as you can see in the red, and correlated with IL-6 levels greater than 100 picograms per ml, indicative of cytokine storm. And the table here shows you the association of SARS-CoV-2 viremia among 212 adults with SARS-CoV-2 in the UK. Again, significant association with severity. So we would anticipate that viremia may be limited primarily to those pregnant women who are critically ill. Now, ACE and TMPRSS2 are entry requirements for SARS-CoV-2 into the cell. And both of these facilitators of cell entry are present in the placenta, expressed both in maternal and fetal placental cells. However, there are conflicting data on the extent of co-expression of these two, which need to be co-expressed on the cells for infection to occur, which appears to be relatively low, whether it's restricted to certain cell types, whether there's differential expression by age. And some examples here are a study that compared expression of ACE2, TMPRSS2, and furin, which is another facilitator, in the placenta in red compared to other tissues, so a little bit lower or the same. The second figure found that ACE2 and TMPRSS2 were restricted to trophoblast cells in the placenta. And the last figure shows that the expression of these two was highest in early placentas and decreased in late placentas. But if you review all these papers, you'll find a lot of contradiction. So is there a potential for ischemic placental injury associated with SARS-CoV-2 infection? And the answer to this is yes. And the data shows you a meta-analysis of 56 studies of over 1,000 pregnancies in which there was a histopathologic analysis of 895 placentas of women with infection. And a significant proportion of the placentas, more than 80%, showed histopathologic abnormalities suggesting placental hypoperfusion and inflammation, and it was similar in asymptomatic and symptomatic infection. Now, COVID placentitis is characterized by SARS-CoV-2 detection in syncytial trophoblast layer of the placenta with intervillous cystitis, increased perivillous fibrin deposition, and villous trophoblast necrosis. And this entity appears uncommon in a study of 271 placentas. The prevalence was only 1.5%, increasing to 5.9% in preterm births. Some studies show that it's associated with low-level SARS-CoV-2 viremia, and some studies suggest it's associated with stillbirth, but not necessarily fetal infection. Among 68 stillbirths and neonatal deaths with placentitis, fetal detection was seen in only 57%. And it's hypothesized that stillbirth and neonatal death is due to placental destruction, malperfusion, and insufficiency, and not due to direct SARS-CoV-2 infection of the fetus. So what about fetal tissue? ACE2 can be found in the fetal lung. The graph here, the little figure shows you in brown the presence of ACE2 at different ages. It can be found as early as 12 weeks gestation with an age-related increase that peaks in mid-gestation. And TMPR2SS2 shown in purple, as well as ACE2 is also found in fetal lung, heart, and liver. So does finding SARS-CoV-2 in the placenta always indicate infection of the fetus? Now, there have been reports of detection in the placenta using a variety of different techniques, but virus in the placenta does not always correlate with a positive test in the infant. And in the references below, there are 13 studies, 41 SARS-CoV-2 positive placentas, 24 infants were PCR negative, 15 were positive, 2 infants were tested. And just a note that testing by RT-PCR is the gold standard, and that if you're not using that, in situ hybridization is more valid than immunohistochemistry with a specificity of 100% compared to about 50%. And also for sampling of the fetus, a tissue sample is preferred to a surface swab due to potential contamination of swab specimens. How about amniotic fluid? So SARS-CoV-2 has been detected by RT-PCR in amniotic fluid in a small number of case reports that are written below. And in case reports of 39 cases of positive amniotic fluid, 29 of the infants were negative, 17 positive, 3 no testing. And one of the largest studies collected amniotic fluid from 42 asymptomatic women with documented COVID-19. 7 specimens were positive, but only 7 infants had positive tests at birth. So what about intrapartum transmission? Intrapartum transmission requires fetal and infant exposure to the pathogen during labor and delivery, that is, contact with infectious blood or secretions during passage through the birth canal, and for the pathogen to infect the newborn. So the questions here: is SARS-CoV-2 found in vaginal fluids, and is it found in the feces? So although there are a few case reports of positive SARS-CoV-2 in vaginal swabs, it appears uncommon. And in 4 cases, 2 had a positive baby, 2 had a negative baby. And in 5 of the largest prospective cohort studies, including 138 women with infection who had vaginal secretions tested, only 2, 1.5%, had a positive vaginal secretion test. But the story is different for feces. And in a meta-analysis review of 95 studies, this is of non-pregnant individuals, 52% had positive PCR in stool samples, with a positive test up to 70 days after symptom onset and remaining positive in 64% after the respiratory samples were negative. Now, the viability of this virus is unclear. It was investigated in 5 studies, and in that, only 35% of patients had live active virus in their GI specimens. But it does bring us to the possibility of contamination of the environment with maternal feces during delivery. And these are data from the University of Oregon that collected environmental swab from room surfaces and healthcare worker face shields and air in birth from 4 asymptomatic women who tested SARS-CoV-2 positive, 2 vaginal deliveries, 2 cesarean deliveries. And they saw that compared to empty room specimens after delivery, there was an increase in the positivity rate in surface and air samples, with the greatest change with vaginal birth. And post-delivery face shield samples were positive in all healthcare workers with the vaginal birth, but none with cesarean birth. What about breast milk transmission? Well, postnatal transmission through breastfeeding requires infant exposure to infectious breast milk and infant infection via an oral or gastrointestinal route. But we know that breastfeeding will usually include exposure of the infant to the SARS-CoV-2 infected mother or an environment. And so differentiating breast milk transmission from horizontal transmission is going to be difficult. SARS-CoV-2 has been only rarely detected in breast milk and generally only transiently. And in a meta-analysis of 50 studies with 183 mothers with infection who had testing of their breast milk, 12 samples were positive, giving a pooled breast milk positivity rate of 5%. And whether the virus that's found is infectious is unclear. There's only been 1 study looking at that, and in that study, no replication competent virus was seen in the PCR positive breast milk sample. Now, in reports of 15 infants who were breastfed with breast milk documented positive for SARS-CoV-2 RNA, 6 infants were actually negative, 9 infants were positive, but 3 of these were in infants whose mothers became infected postpartum, so horizontal transmission can't be excluded. 4 had a positive PCR prior to receiving breast milk. 1 had a negative PCR at birth, received only expressed milk for 24 hours and was positive at day 4. So has SARS-CoV-2 infection via the oral or GI tract been shown? Not yet. And is SARS-CoV-2 antibody found in breast milk? And the answer here is yes. IgG, M, and A have all been detected in breast milk. And this shows you a meta-analysis of 10 studies reporting on antibody testing in breast milk of 89 mothers. And of these, 61 had antibodies detected in their breast milk, giving you a pooled prevalence of 83%. Now let's move to defining and categorizing timing. The World Health Organization convened a multidisciplinary international panel of experts in late 2020 to review the evidence and to propose a consensus initial classification system for timing of vertical transmission. And they came up with in utero live birth, in utero fetal demise, intrapartum definition, and early postnatal transmission. And 3 elements were required to classify true infant infection and timing. The first was documented maternal infection, and that could be any time during pregnancy for in utero infection, but had to be near the time of birth for intrapartum and early postnatal infection. Secondly, you had to have initial testing at an appropriate time. So for example, to evaluate the likelihood of in utero infection, you had to have testing done at less than 24 hours. And for intrapartum exposure at 24 to 48 hours. And then finally, and very importantly, you needed confirmatory testing to evaluate persistence of the virus or persistence of the immune response to be able to definitively say an infant was infected. So the University of Birmingham is also doing a living systematic review of COVID-19 in the infants. And as of August 21st, includes 472 studies, over 28,000 mothers, over 18,000 infants from 66 countries, 206 cohort studies, 266 case reports. So 1.8%, the red box here, of over almost 15,000 infants tested in cohort studied had a positive RT-PCR, and if you included IgM, it went up to 1.9%. Now, if you limited this to infants born to mothers who were diagnosed antenatally in green, so that you didn't have postnatal transmission, the rate was 1.3%. And if you limited in the purple box to infants tested in the first 24 hours after birth, giving you potential in utero infection, the rate was only 0.9%. So there were a number of factors associated with infant SARS-CoV-2 positivity, and all of them primarily related to severity of maternal disease. Severe COVID-19 in the mother increased the risk of infection in the infant, detection of virus in the infant, 2.4 times maternal ICU admission, 3.5 times maternal death, 14.1 times, and postnatal versus antenatal, 5 times. So postnatal infection causing horizontal transmission. Factors not associated with infant positivity were trimester of infection, prematurity, mode of delivery, breastfeeding, or separation of the dyad at birth. So they then took the WHO classification system and took 988 infants with positive SARS-CoV-2 PCR tests in these studies. Of these, 396 or 40% lacked enough data and description to determine the certainty or timing of infection. Of the 592 infants who tested positive who had sufficient data for classification, only 14 could be classified as confirmed or definitively infected, 4 in utero, 3 in utero fetal demise, 2 intrapartum, and 5 early postnatal. And that's because testing was very rarely done in the newborn period, and confirmatory testing to prove infection was very uncommon. This look at the outcomes for 800 SARS-CoV-2 positive infants from 247 cohorts, case series, and case reports. The majority of the infants were healthy, 94% were alive at end of follow-up. There were 8 early pregnancy losses, 1%, 20 stillbirths, 2.5%, 23 neonatal deaths, 2.9%. So of the 7 infants with confirmed in utero infection, 4 live births, 3 demise, 3 were alive, 1 died after delivery. There was 1 stillbirth and an early pregnancy loss in twin fetuses. In contrast, all of the infants with confirmed intrapartum and early postnatal infection were alive at the end of follow-up. So confirmed in utero infection may be associated with adverse outcome. So intrauterine infection is going to be rare. Placental infection is rare, more likely in mothers with severe COVID-19 because of viremia or disruption of the placental barrier. And in these cases, placenta, amniotic fluid, and/or neonatal blood may be positive, but persistence of virus is important to be able to determine definitive status. Peripartum, intrapartum, or early postnatal is possible. Vaginal secretions are really positive, but we have high positivity in the feces. These infants will have a persistently positive PCR in a nasal swab the first week of life. The vast majority appear asymptomatic, minor symptoms in most. And breast milk infection is going to be unlikely. Infection through viral presence in breast milk is unlikely, and more likely is horizontal transmission through respiratory secretion contact. So I want to end talking about COVID-19 vaccines in pregnancy. So this was a meta-analysis that looked at 6 observational studies on the efficacy and safety of COVID-19 vaccines, primarily mRNA vaccines, but also adenovectors in almost 41,000 pregnant women. 5 studies here, if you look on the right, looked at effectiveness on infection. And the pooled odds ratio was 0.49, so vaccine was significantly protective in terms of infection. 2 studies looked at hospitalization. Again, the pooled odd ratio was 0.5, so vaccine was significantly protective against hospitalization in pregnant women. And there were 2 sparse data on really severe COVID ICU admission and death. This looks at the effect of COVID-19 vaccine on maternal and infant outcomes, and it's a population-based study in Ontario, Canada, that used both birth registry and COVID-19 vaccine registries, and comparison groups were women who got vaccine during pregnancy, vaccine after pregnancy, or no vaccine. And they used propensity scoring to compute the inverse probability of treatment weights to account for potential confounding. So the chart on the left shows you the comparison of vaccine during pregnancy compared to vaccine after pregnancy. And the one on the right shows you vaccine during pregnancy compared with no vaccine. And in the red boxes, you see the adjusted odds ratio, and you can see that vaccination during pregnancy was not associated with an increased risk of any of these adverse outcomes. And actually, vaccinated women had a lower risk for some outcomes, such as NICU admission. This study looks at infant IgG serum antibody after either maternal vaccination or maternal infection and durability of the antibody. So 77 infants of mothers vaccinated at 20 to 32 weeks gestation, and 12 infected mothers who had symptomatic infection at the same time were assayed for IgG antibody in the mothers at birth, in cord blood, and 2 and 6 months. So higher maternal SARS-CoV-2 IgG titer was present at birth in the mother and in infant cord blood in vaccinated, this is the blue is vaccinated, then infected, shown in orange, mothers. At 2 months, 98% of the vaccinated mothers had detectable IgG, and at 6 months, 57% of the infants of vaccinated mothers had still detectable IgG, compared to only 8% of infected mothers. So natural infection did not result in as good protection for the infant as vaccine. This study looked at human milk antibody response to COVID-19 vaccine, and it was a systematic review of 18 cohort studies reporting on IgG, which is shown in pink, and IgA, shown in blue, in breast milk after receipt of COVID-19 vaccine. And these were primarily mRNA vaccines. So breast milk IgA was present in 64% after the first dose, that's shown on the left, and 70% after the second dose on the right. And IgG was present in 30% after the first dose and 91% after the second dose. So good antibody production and good antibody production that goes into milk to the infant. This shows the effectiveness of maternal vaccine during pregnancy against COVID-19 hospitalization in their infant less than 6 months. So this is a case control study in 20 pediatric hospitals in 17 states in the US, looking at maternal 2-dose mRNA vaccine during pregnancy, and they looked at COVID-19 hospitalizations in infants aged less than 6 months. There were 176 infant cases with lab-proven COVID-19, 203 test negative controls that were matched on site and date of admission. So on the top, you look at maternal vaccine efficacy in preventing infant hospitalization with COVID-19 was 61% overall and 80% if given after 21 weeks gestation. And the bottom shows you severe COVID-19 illness in infants. 88% of those admitted to the ICU, and both cases of ECMO and death had unvaccinated mothers. So vaccine is really important for pregnant women. So in summary, pregnant women are more likely to have severe disease, and severe disease is more common with obesity underlying conditions, possibly women of color, as in the general population. There are few reports of first trimester infections, so the effects of early infection are not clear, but if the mother recovers, it appears to be minimal. There are bidirectional adverse effects of pregnancy on SARS-CoV-2 disease and SARS-CoV-2 disease on pregnancy, maternal, and infant outcomes. Transplacental infection is rare. Peripartum infection can occur, but is uncommon, and there are no proven cases of breast milk transmission. Most SARS-CoV-2 exposed infants and their mothers actually do relatively well. And finally, and importantly, SARS-CoV-2 vaccine is effective and safe in pregnancy and potentially protective against infection of her infant. And thank you very much for your attention, and happy to take questions.
Thank you. That was a wonderful presentation, as usual. Thank you very much. We're just waiting. People in the audience, please do put in your questions into the question box. I'll just start it off by asking, do you have any comments? Is there much data on vaccination in the first trimester? It seems like a lot of the data is 20 weeks and beyond.
Yeah, no, most of the data does reflect second or third trimester. I would have to go back and look at the specific articles that were reviewed there to see how many is first trimester.
Yeah, and in terms of protecting against COVID, you presented nice data about IgG and IgA antibodies in maternal breast milk. Was there any data about cell-mediated immunity to the virus in breast milk?
No. The studies in breast milk are, small, and there have been no cell-associated immune studies that I know of, anyway.
And do you think that screening of pregnant women in labor, it seems to be primarily a research phenomenon? Do you know how widely it is still being done in the US? I know in Canada there's been most screening programs in labor have been shut off.
Yeah, I think a majority of programs have turned it off. It started in New York when they had such a high prevalence. And it's a good question. I'll have to ask my colleagues in New York City whether they're still doing universal screening. I can't say that I know if they are or not.
Okay, so we have some questions coming in. So the audience, let's see, okay, try. Most studies of COVID-19 in pregnancy were conducted in unvaccinated women and or during the pre-Omicron period. What is the risk of adverse maternal outcomes or pregnancy complications in vaccinated and boosted women against Omicron and its variants?
Yeah, so if you look at the data that I presented, first of all, vaccine is protective against disease, both infection and disease. So vaccine is protective. And the data, the limited data that looked at Delta versus Omicron suggested that Omicron causes less severe disease. I wouldn't imagine that the efficacy of the vaccine in pregnant women is going to be any different than the efficacy of vaccine in non-pregnant individuals. So I think we would see the same thing.
So there's another one along the same path. Do we know the effect of booster doses on efficacy on maternal and neonatal outcomes versus 2 doses?
Yeah, good question. And I can't say that I've seen any papers that have addressed that yet.
Okay, so there's a question from Fatima Kakar, and I wanted to ask the same question too. Is there any emerging data on long-term outcomes like hearing or neurological among infants exposed in the first and second trimester?
Yeah, really good question. And I think the studies are just starting. I know that I have a colleague who's doing research in Uganda who's going to try to look at long COVID symptoms in HIV positive and HIV negative mothers. I've seen no data, written data on long COVID in pregnant women, after they're finished with their pregnancy, and really no data on follow-up of infants past whether they lived or not lived.
How about on the altered in utero environment that these infants, fetuses are exposed to because they're going through a COVID and maternal COVID infection? Is there any studies that are planning to look at whether there is any infant outcomes of just being exposed to increased inflammation or whatever it is?
Yeah, there's been some interesting hypothetical studies that have said, oh, well, hypothetically, these increased cytokines will cause problems for the babies. I don't know specifically of people that are doing the study, but I am sure that the cohorts that set up of pregnant women with cohort are continuing to follow those infants. So hopefully we'll have some data from those studies within the next year. It's a very good question, really good question.
Mike? Oh, you're muted, Mike.
It's the first time I've used Zoom. So one question from the audience was, why was there so misinformation about vaccines in pregnancy and breastfeeding in the early days? And what is there anything you recommend we should do differently next time?
Well, that's a good question, but I have to say, at least in the US, I feel like the political environment is such that it created this huge amount of misinformation, more than there would even be if there wasn't the political. So I'm not so sure that some of this isn't just related to the overall current lack of trust of physicians, research, and public health officials. How to do it differently? Boy, that's a good question. And if I answer what I think, it will be politically incorrect in the United States. So I'm not gonna.
But this is a safe Canadian space. So you.
I don't know. There's Ottawa's on too, and Ottawa recently, but and I guess just for the record, just to say, I mean, one of the biggest things of misinformation was that the vaccine caused infertility, and just to comment, just for the record.
Yeah, I didn't add that to there are a number of studies showing that that's not true now, but I didn't add that to that. My talk was pretty long as it was. So.
Any other questions from the audience? I encourage you to put them in. There is one question that's related to the previous one. Could you comment on vaccine hesitancy, which tends to be higher amongst pregnant women and women of reproductive age?
Yeah, I think it is really incumbent on us as physicians and people who care for pregnant women to talk about vaccine and what is known, and to reassure them. I don't have a great way to say other than that individual patient to physician contact is important. And I would urge that everyone be urging their pregnant patients to receive vaccine. I think not just for their own health, but I think we now know it's for their infant's health as well.
Yeah, so there's an interesting question here. Is there any difference between pregnant and non-pregnant on how fast the vaccine protection weans out? So is it better to get your vaccine before you choose to become pregnant, or is it better to get it in pregnancy?
Well, there's some difficulty with all of these studies that are reporting on antibody, right? Because we actually don't know what's protective against SARS-CoV-2. And, I keep seeing these papers coming out about T cell response persisting for a year after vaccine, even though antibody has gone down. So I don't know. I would say that a woman who is pregnant, who's young, may not have received vaccine before she was pregnant, but I think pregnancy constitutes a high risk situation where she should receive vaccine if she hasn't already. I certainly wouldn't tell anyone to delay receiving vaccine until you get pregnant. If you need it, you should get it.
No, we have questions coming in. Mike, you want to take the next one?
Yes. So we seem to keep having the same problem of early inclusion of pregnant women in studies. How can we better address this for the next pandemic?
Great. How to fix this? It's a good question. WHO and Impact had set up a year-long working group trying to develop some very specific guidance for the pharmaceutical companies and regulators. And there's going to be a supplement in the Journal of the International AIDS Society on this. And I think that there is an increasing push towards studies in pregnancy. In addition to the WHO impact work, there's the US PregWac advisory committee to the president, and the phases group did a report on ethics. So I'm hoping that we're coming to the realization that we need to do these studies. And while I'm an HIV doctor, while I feel like delay for HIV has been so bad, HIV is actually a model for all of the other conditions. We've done earlier studies in pregnancy in HIV than for most other conditions.
Yeah, that's a good point. So we have a question about, has anyone looked at peer support as well as healthcare worker support in combating vaccine hesitancy in pregnant women?
That's a good question, and I can't say that I know. It's not something that is my area of expertise. I would think that both would be important and useful. Based on HIV, peer support certainly is important, but I haven't seen anything specific for this.
And do you know? Is there even animal model data available on Paxlovid? I'm not sure. I know you mentioned it, but I mean, there's been concerns about long-term use of protease inhibitors with HIV in pregnancy, but here we're only talking about 5 days of use.
Right.
Have any thoughts about that?
Yeah, the animal data to me look very reassuring, and the data in pregnancy are pretty reassuring as well. The main thing that has been a concern is the boosted protease inhibitors in preterm delivery, but that's with extended use. I don't think 5 days of use of relatively low dose ritonavir is going to be an issue. I would be very comfortable giving a pregnant woman that drug as well as remdesivir or the monoclonals.
Yeah. I mean, it is the same dose as we used to use for lopinavir ritonavir, but it's for a much shorter period.
Right.
Lynne, have there been any comparison studies on placenta pathology for Delta versus Omicron?
It's a good question. I haven't seen any at this point. The placentitis studies that I presented, those are all relatively new, but none of the studies said, oh, this is Delta versus Omicron. It may be that the studies are being done, but they're just not published yet. You have to do the study, complete it, write it up, get it published.
Yeah.
It takes a long time.
Although it has gone much quicker during the COVID pandemic, we definitely learned how to do that quicker.
Yeah.
Well, we're coming to the end of our session. There was a question about whether the slides will be available, and lots of comments about how great your presentation was, as always. So the presentation slides will be available in the enduring material. So, you will be able to reference this. Your slides are always like a reference. Yeah, the recordings will be online. And again, thank you so much for an excellent presentation. It was such a pleasure to hear you speak, as always.
Thank you. It was a pleasure to speak, and good afternoon, everybody.
Yeah.
Bye.